Right. Good afternoon, everybody, and Happy New Year. The first INN of the year, and this is our second year. So we went through the first year, and thank you very much for everybody coming on the ride with us. And hopefully, we can continue this for a second year now. Um, really happy to have Yona joining us today. So Yona is the African Program Manager for Smile Train, which is a cleft lip charity, and she's going to be presenting on her work that Smile Trains does and how that can link with Noma. So over to you, Yona.
Thank you very much, Stuart. Good afternoon, everyone. Uh, as Stuart has mentioned, my name is Sibusisiwe Yona, but you can call me Yona. And I work for Smile Train. Maybe some of you have heard it. I've seen a lot of participants from Nigeria. It's quite big in Nigeria, our program. I'm sure you've heard of us, or if you haven't, then maybe this is your opportunity to learn more about us. So I work as the program manager for East and Southern Africa, and I am based in Zimbabwe. So I've been working in the field of cleft lip and cleft palate as a program manager for the last 10 years. So I have a bit of experience in this field, but more from the programming side, not the clinical side. And you will understand why it's so important for us to be working together with social scientists because of the work that we do. It depends on our society runs. And my topic today will be the overlap between cleft lip and Noma, highlighting both the medical and the social aspects that connect these two conditions. I hope this presentation provides valuable insights into how these conditions intersect, inform each other in both diagnosis and treatment. Feel free to ask me any questions at the end of the presentation, and I'll be happy to address them. But I hope we will have a good discussion about what I'm presenting today. So I'll start off by explaining who Smile Train is or what our organization does. So Smile Train is an international charity with a sustainable approach to a single solvable problem, which is cleft lip and cleft palate. So we are located in quite a number of countries, and the organization started in 1999, and we have been in over 90 countries around the world. A lot of them are also in Africa, and I think 42 of them where we are working in the African continent. So we are focused on the single problem that I mentioned, which is cleft lip and cleft palate. So these are some of the beneficiaries of our program. I don't have the after pictures here, but I wanted you to see the condition as it is for the sake of the presentation. So our model as an organization is to teach a man to fish. So we believe that you give a man a fish and you feed him for a day, you teach a man to fish and you feed him for a lifetime. So I'm sure a lot of you have heard this statement spoken quite a lot. But for us, we take it quite seriously because we believe that the solutions to the cleft problem and the solutions to the treatment of clefts in Africa lies within us as practitioners. And so we have a lot of partnerships throughout our program in the 42 countries in Africa. We've got over 1,100 partner hospitals. We've got more than 2,100 partner surgeons, and we've done 1.5 million pre-cleft surgeries globally. But in Africa, we have done more than 100,000 since Smile Train started in Africa. So our areas of support include awareness, where we talk to the communities about clefts and make sure that children who are born with clefts are not left out. They get access to care. We also help hospitals by providing equipment. We do research and we provide speech, nutrition, orthodontics, which are comprehensive ways of treating clefts, not just looking at the surgical part of things, but also ensuring that the child speaks properly, that the nutritional aspects are dealt with, and then the orthodontics as well, which are problems that a lot of our cleft patients face. So we do this through surgical partnerships, through those hospitals that I've mentioned that we've got about 1,100 partner hospitals and more throughout Africa. So every year, we find that about 200,000 children are waiting for surgery. Either they are born, they're on a waiting list somewhere, maybe it's an adult as well who has never had access to surgery. So we have this issue that at least 200,000 patients will be having untreated clefts that need to be treated. So now I get to why we are here today. So Noma and cleft overlap. Both conditions can involve the mouth and the face, which might lead to confusion, especially in regions where Noma is more prevalent and less known, while cleft lip is more recognized globally. Also, the appearance of someone with Noma might superficially resemble facial cleft deformities, though the causes and the treatments are very different. So here is a side-by-side picture of a child with a cleft. The one on the left has a cleft, the one on the right has Noma. And I know a lot of you are medical professionals, you probably know this already, but the patients do not know this. So you'll find that when we do our campaigns on raising awareness about clefts, some Noma patients also come because they don't know that they don't have a cleft. They're just listening to what they're hearing on radio or during road shows or seeing on a picture because they kind of look similar. So you will find that the cleft lip is a congenital deformity which is present at birth, while Noma is acquired and often develops in children who are malnourished or suffering from other underlying health issues. Noma is more progressive. Noma develops rapidly, often causing life-threatening tissue destruction, whereas cleft lip is structural. It's an issue that requires planned surgery over time. This is why I mentioned that we do nutrition programs as well, because we need to make sure that the patients are optimal for surgery. So cleft lip is usually corrected in its infancy, which is what we encourage, although we do find a lot of adults who come as well, and we do not turn them away, we treat them as well. So the long-term outcomes also of clefts encourage that we treat it as early as possible so that we can have the best outcome and that the patient can also be treated and go through the treatment pathway so that we can avoid other issues such as speech difficulties and whatnot. So while Noma survivors may face extensive reconstructive surgery over time because it's a progressive condition, they would need rehabilitation and they lose some tissue and a lot needs to happen. So both conditions require surgical intervention for restoration, though the type of surgery and the reasons for it are different. In the case of Noma, reconstructive surgery focuses on restoring facial appearance after tissue loss, whereas cleft lip surgery is aimed at correcting a congenital gap. So science hasn't gotten to that place where we can say we can avoid or prevent clefts from occurring. Yes, there's been research around folic acid and all those things, but nothing has yet been concretized on what exactly can be done to prevent clefts. And since it's also believed that clefts are also genetic, it's also very difficult for you to say you can prevent it. But with Noma, we can definitely prevent it. So these are our cleft babies as well, again. And these are some Noma cases that I took online from the Lancet photo library. So you can see it will attack your whole face and then your tissue necrosis is what occurs. So one of the things that we have seen from what I've mentioned before is the absence of specific terms. In many regions, cleft lip and cleft palate do not have a commonly used or recognized local name. So I'm in Zimbabwe and I speak Shona. That is my local language. We don't have a name for cleft in Shona. And we don't have it in Ndebele. We don't have it in any language that is spoken in Zimbabwe. And here we speak 16 languages. So from what I have known, from where I have actually visited in some countries, you'll find that the only place where I have seen where they have actually got a name for a cleft is in South Africa, and it's in the Zulu language, but not in the other languages. So it's very difficult for you to call out something that you cannot name. So a cleft is often referred to in general terms like split lip or gap or tear or whatever you call it, the way people describe it. Similarly, a palate may be described as a hole in the roof of the mouth or a mouth gap or so many things. And then the impact of that is that it's difficult now to identify and discuss. Without a clear, commonly understood term, it becomes challenging for community members to easily identify or communicate about the condition. And then it leads to inconsistent descriptions. Local descriptions can vary widely, and interpretations of these descriptions can differ from person to person. So I'll give you examples of some experiences I've had. So, because you cannot name something, you normally don't know how to fight it, or you normally don't know how to solve the problem. I once visited a patient in a place called Wedza here in Zimbabwe. It's a rural area. So we had gone to visit a patient who we had operated on when she was 5, but at the time I visited her, she was 13. So we now were interviewing the mother and we were asking her, what do you think the cleft came from when you gave birth to your child and you found that they had a cleft? And then the mother said something very interesting, which I will never forget. I always use it as an example in my presentations. She said that when she was pregnant, she used to like eating crickets. So I don't know if you know those little insects that make a lot of noise, which are called crickets. So this mother used to consume these. They used to roast them and then she would eat them when she was pregnant. So crickets happen to have a cleft naturally. That's their anatomy. That's how they were created. They have a cleft. So in Shona, we have got a word that is called nodzera, where if a child comes out looking like your sister, you just said they have nodzera from your sister. They took after your sister. So in other words, this lady was saying, my child took after the crickets. This is why the child had a cleft. It was very interesting to hear how, you can form ideas, you can form your own facts about something without really verifying whether it's true or not. And then that prevents you from seeking care because you think it's an act of God. You think it's something that happens, but nothing can be done about it. So just put yourself in the shoes of those people who are sitting at home with untreated cliffs and what could be going through their minds. So we rely a lot on descriptive language when we are doing awareness. So mostly when we put information on buses or on posters, we just say, if you have a gap on your mouth, or if you have a hole inside your mouth, this is how we describe a cleft. So you could really see now that this is why some people would probably think that Noma is a cleft, because we are describing it the same way you would describe Noma if you were to describe it. So these descriptions can be understood differently, like I've mentioned. And descriptions such as a gap in the mouth or ulcers on the face could easily be taken differently. And this is why you now see people not knowing which condition you are describing when you are trying to do your campaign. So it becomes general and it doesn't really serve the purpose of what you are trying to do in the long run. So this now keeps the people at home and they don't seek treatment. So it now leads to shame, isolation, pain, and heartache. And a lot of the cases that we've heard, it has also led to very serious things like divorce, like suicide, and things like that, because people don't understand the condition. The condition has no name in our culture, so it's something that is that constitutes a curse in other ways. So children born with clefts may face social discrimination, and children who survive from Noma may face also long-term physical and psychological challenges, including disfigurement and trauma from recovering from the life-threatening infection. And both conditions can lead to social stigma and psychological challenges relating to their appearance, especially if left untreated. So the emotional impact of having these conditions is associated as well with severe illness and life-threatening complications. So how do we spread awareness? So we need to develop clear, simple terms, and I will emphasize on the word simple. Remember, when you are in the cities, like here in Harare, when somebody sees it on TV, they have got access to TV, they can see what you're talking about, they can hear other mothers talking on the TV or healthcare professionals talking and describing what they are talking about, and they can be told, you can just come here. So the information and the care itself is very close to them. So we need to make it so simple, because our target is actually not even those people in the cities. It's more the people who are in the far-flung areas, in the rural areas, where access to information is a challenge. And then when the information goes there, it's also not very clear. So we need to collaborate with local communities, linguists, and healthcare workers to create specific and understandable terms for cleft lip and palate or for Noma that can be used consistently. So standardized descriptions in awareness campaigns and the use of visual aids, because visual literacy is very, very important. Because visual literacy can show you what is being described, and it can give you a better idea of what people are talking about if the description itself is falling short. So for me or for you who is in the healthcare profession, it's very easy for you to see this is normal, this is a cleft. But for the untrained eye, it's very difficult. So visual aids come a long way into explaining, and also the language that is used and the information provided, that a cleft is something you are born with. Norma is something that you get. And then so we emphasize the difference between cleft lip and norma, and then you have your visual aids and localized narratives. And you can say these things in the local languages. You can have people who have had the treatment speaking in their local language about the condition. This will also be able to help. So now when it comes to us, the practitioners, the people who are trying to help, we can work together by developing clear referral guidelines and creating protocols together that will help us establish a clear and easily accessible set of guidelines that explain the differences and overlaps between clefts and norma. These guidelines can help us as professionals. They can help community health workers distinguish between the two, highlighting the specific signs, risk factors, and symptoms of each condition. We can have referral flow charts so that healthcare professionals in the rural areas can know where to send the patients. And then we can clarify the importance of timely referral as well, especially for conditions like norma, that is progressive. And then if you just take your time, the face will be eaten away, and then the condition will become worse and worse faster. A cleft is something you are born with. Until you are treated, you will just remain the same. Nothing will significantly change there. So collaboration is very important as well. We train healthcare workers on both conditions. So I know UNICEF, as an example, has got a community health worker handbook. So we can train healthcare professionals and make sure that we also collaborate with such organizations that have got a bigger footprint than us, to make sure that the conditions that we are trying to assist are also in the handbook. As far as I'm concerned, I've never seen a surgical condition in the UNICEF handbook for community health workers. It's mostly communicable diseases. And at the end of the day, as common as clefts are, you find that they are not even there. This is where we can also try and go and collaborate with those organizations to make sure that we are included. When the community health workers go out there to look for patients for malaria or whatever, or for HIV, TB, they come across normal patients, they come across cleft patients, then they will know to refer them to us. Because the challenge is people not knowing where to go and staying at home without any help. So leveraging community engagement and education is also very important. So you will find that the community health worker program that I've mentioned, they have trainings that they do there. You can go there, and then we can ask them to actually include what we do as organizations to find out where we can, when they meet, and how we can go there and talk to them and ensure that we are included. Because if we do not go there to actually ask to be included, it means that the people who are supposed to be getting help from us, they end up not getting help because we haven't presented ourselves to them to say we are here, we can support, this is where the patients can come. So I will talk a lot about the awareness raising because it's what is the backbone of our programs. If you do not create awareness, people will probably not even know that whatever you provide as assistance exists. And they stay at home because of various reasons, some of which I've mentioned, that they think it's as an act of God, and some of them are afraid of the costs. And then those of the patients who are not afraid of the cost, who are willing to come with their children, some of them are actually afraid of anesthesia because they don't know the process. They think that when you get anesthetized, you die. I've actually heard patients say things like that, that the doctor will anesthetize my child and my child will die, then they resurrect the child. Honestly, if this is what normally happens, we wouldn't have anybody dying. but there is a lot of misconception out there. And if we don't go out there and give out the information about the conditions, then you will find that people will just remain there ignorant and not knowing where to go to ask for assistance. And one of the most critical ways of making sure that people get information in the way they understand is to use patient testimonials. Those who've been treated, if they are at an age where they can speak and communicate, you can use their testimonials. Those who cannot yet speak, their parents can speak for them. And this also helps to build trust as well in the community, and also know that people, when they hear other people saying, I got help, I went there, nothing bad happened to me, then they will be free enough to come and try also to participate or to get treatment. So the partnerships that I wanted to mention are the collaborations. I've mentioned UNICEF, but one of the things we can do is also the sharing of resources and materials. I know when it comes to surgical diseases, it's very hard to get funding. That's another another topic on its own, which we could spend the whole day on, to say, okay, fine, how, where do we get funding? Who will support the program? It's very, very difficult to get funding in this space. So at the end of the day, as long as they don't consider it an emergency, they probably will not help you. With Noma, it's different, but at the same time, it's a surgical problem. So you'll find that funding in our circle is very difficult to get. But as much as we would like to just sit there and hope for the best, we need to actually go to these people like the World Health Organization and work with them to see where we can get included. We can go to other civil society organizations, and sometimes it's not even about funding, but it's about sharing resources, increasing our network of local healthcare providers that are around us who can help us create a referral system and a referral network. So you will find that for the awareness bit, we can piggyback onto vaccination campaigns and things like that, so that when they come across our patients, they send them to us. So I would like to talk about this technology in creating awareness. So we've got digital referral systems for tracking patients. At SmileTrain, we've got what is called a Smile Finder app. That's the screenshot of what it looks like when you open it. So it's found in Google Play Store. You can find the Smile Finder app. And this is an app where, for example, when you go inside the app, it will give you a summary of what a cleft is. When you go inside the app, it will also tell you what a cleft is in other languages, not in just English, in French, in Portuguese. It can tell you what a cleft is. It can tell you what a cleft palate is, what a cleft lip is, what types of clefts exist, where to get help. It's got GPS locations of our hospitals. So if you use this app whilst you're in Harare, for example, it can tell you the nearest center where you can get treatment for a cleft for free is at this place. It will tell you the center that is closest to you. So it not only has information about clefts and what clefts are or how they are treated, it also has where you get treated. And then there is an opportunity for you to actually register the patient in the system using this app. And then it will inform us that there's a patient who has been identified, and this patient will be contacted, and then we'll be able to treat them for free. So this is another way we can leverage on technology, because technology itself, it helps to cut down a lot of costs. And when you have apps like this, you can make sure that whoever is in the community who has heard about the app can download the app and use it to refer patients. So the similarities I've mentioned between Noma and cleft lip and palate, they will remain similarities to people in the community. To me and you, we know the difference. But a lot that we have done as an organization, as SmileTrain, I found that the moment you increase your community engagement by working with other people, working with other organizations, using these kinds of technologies, going to schools, talking about Noma, talking about hygiene, it really helps to further the cause of what you're doing, to ensure that people actually come across the information that you have, so that when they come across Noma cases or cleft cases, they will know that it's time to go to the hospital. It's not time to sit at home. When you explain to them what can happen when the treatment doesn't happen, that you can have your whole face eaten away if you don't treat the noma, or you can lose your speech and you can become malnourished if you don't treat your cleft. Then they usually take action to want to come. But like I said, we do have some challenges that we do have there, where language itself is a barrier and all other things like funding and resources. But there are other ways that we have been using over time that we can also try to take up in looking after or looking for Noma patients and creating awareness like the ways that I have mentioned, creating networks of organizations, even if they have got nothing to do with what you do exactly, as long as they are community facing, they are very important to the program. So in summary, raising awareness within the community and among healthcare providers is very critical. Empowering healthcare workers to identify both conditions and understand when to refer is also another critical part. And then collaborating, bringing together specialists with various fields from various fields to provide comprehensive care, and creating referral systems, ensuring that clear, efficient pathways exist to ensure the correct treatment at the right time. So one of the things I would like to mention here is the job of practitioners. We as practitioners have a very critical job. Most of the practitioners that treat clefts are the same practitioners that will treat Noma. The ones who work in reconstructive care, whether they are plastic surgeons or whether they are craniofacial, maxillofacial surgeons, they are the same people who are going to treat those clefts. So sometimes you are just maintaining that referral chain that you have always used, the same people that you know, the same people. I'm sure there are people in this meeting who actually treat clefts as well. So those very same people can be very instrumental in making sure that Noma patients get the help that they need at the right time. Just piggybacking on other people's programs is actually an easy way of getting your program to be known, getting the research out there to the people. And so by combining these elements, we create a more responsive, coordinated healthcare system that ensures all children receive appropriate care, whether they are affected by cleft lip or by Noma. So if you'd like to know more about Smile Train or become a partner or for patient referrals, both ways, Noma and clefts, you can contact me on those numbers. And this is the end of my presentation. I hope I have earned the privilege of your attention and time. And let us work together to make a better place for patients with Noma and patients with clefts. Thank you very much.
Thank you very much, Yona. That was a fantastic and very insightful talk. Thank you very much. I see we've got a few questions coming in already. I think I'll start if I may. So you talked about the similarities between Noma and cleft lip. Does Smile Train have any sort of plans to make Noma more one of the core themes of what they do, considering how often they see it and come across it?
Okay, so at the moment, Smile Train only just works in clefts. There's nothing that's been discussed yet about getting into Noma. But when we do come across those patients who have Noma, especially when we go out to do our awareness activities, we do refer them to some of the surgeons that we work with who are in a position to treat the Noma cases. So I'm saying it this way because when we do the awareness campaigns, it's actually different from when you are at the hospital during treatment. So I can go out with some volunteers and say, I'm going to do a road show in the village somewhere, or we can go on radio. And then when patients call in, we do take our time to understand what they are talking about. Because remember, it goes back to what I mentioned about people not understanding. Sometimes when you are describing clefts and then you now say, okay, do you have WhatsApp? Then the person says, yes, I have WhatsApp. Can you go and take a picture of the condition? Then they take the picture of the condition and then you know what it is. So I had one case of Noma that I received from, it was just like a random person because they saw our advert on the bus. So on a bus, some of the buses that go to the rural areas, we had a picture like this, like the boy who is here on the screen with a before and the after of the cliff. Then they saw a boy like this in a place called Murewa, but the cleft itself was on the bottom lip. So that's something that's very rare to find somebody with a cleft on the bottom lip. It's not I've never seen it in the 10 years I've worked in clefts. So I knew that this is probably not a cleft, it's probably Noma. So I sent it to our surgeon who said, yes, this is Noma, I can help the boy. And then we got the boy to come to Harare. So this is how we can now work together. The referrals are very critical in this sort of collaboration. I hope I've answered you.
Yep, brilliant. Thank you very much, Shona. So I think we'll move to the questions with the hands up. So sorry if I mispronounced your name massively. Yakubu Ibrahim, do you have a question?
Thank you. Yes, sir. Thank you. Good afternoon, everybody. Good afternoon, the presenter. So you have normally pronounced my name. I'm Yakubu Anas Ibrahim. I'm a consultant psychiatrist. Thank you for your wonderful job. Please, what efforts are you trying to make, or effort have you made towards mental health aspects of Noma survivors? Because we know, for obvious reason, because of the importance of the face, cosmetics among other things, despite surgical intervention, a normal patient can still have some remnants, scar to the face, and that may actually contribute to some form of stigmatization and how they're accepted in the society. Ma, what have you done so far, or what are the efforts have you done concerning the mental aspects? Thank you, ma.
Okay, so thank you for your question. So I can answer this by telling you how we have done like psychosocial support workshops. So we have done psychosocial support workshops, and most of the time you find that the people who show up at these workshops are women. And I don't know if the men are not there, but sometimes you know how it is with men with cultural issues, they normally don't show up. But we have done psychosocial support workshops, and we talk to the patients. So in these workshops, one of the things that we have discussed is the issue of what happens when you have surgery, what happens after surgery. And we have had like really candid and open discussions. And I think maybe it was also good that some of the workshops that we did, the majority were women, because they could say anything. So you found that some of the concerns that they had were the ones that you are mentioning right now about appearance. How will the baby look after? How will they live after? Will they be able to eat? Will they be able to? So many questions. And the example I gave on patients being afraid of anesthesia actually came out of one of those workshops, because we asked them, so what do you think happens when somebody's anesthetized? And then I think 75% thought the person dies and then the doctor resurrects. So one thing that we did, which was good, which was like maybe foresight, was to bring an anesthesia physician to that workshop. So she managed to explain what actually happens when you are being anesthetized. So talking to the patients and engaging them at their level is very, very critical. Because first of all, if you don't do that, they don't trust you enough with their life. So they will not come for surgery. If you don't do that, they don't understand what happens, because sometimes they will just trust you because, okay, you are the doctor, you are the one who knows, you are the educated one, and they come, but still they don't know what happens after. So obviously when a patient comes for surgery, the extent of the damage itself is something that you will need to discuss with the patient and provide counseling. So we have got a very large support group for cleft patients, which is with one of our partner organizations, which is called Sumiro Trust. So most of the patients that we have done, almost 500 or so of them are in that group. It's a WhatsApp group where they talk, where they ask questions, so many things, they give each other support. Even when we go out to do the awareness, I actually go out with a lot of the mothers who have benefited from the program and some of the new mothers who are new to the program and waiting to receive care. So it just boils down to you talking to them and creating a community where there are people like them who understand them at their level and who can encourage them as they go. I hope I have answered your question.
Thank you, Ma. It's an attempt from what you have done to answer my question. But to give a good support psychologically, it will start by identifying the major mental illness and probably treating it. Because in the management of mental illness is actually, we follow what we call biopsychosocial. Some patients
Yes.
will actually present with frank mental illness ranging from depressive disorder to psychotic illnesses. So in such kind of individuals, severe form of mental illnesses, we need to give them psychotropics, meaning drugs, to treat them first. When they are better, so we give the psychosocial support. So I don't know whether, if, as a form of suggestion, if we can incorporate routine screening for major mental illness, and those that are found to have one or two mental illnesses can be referred or treated appropriately. I don't know whether it will add up to the quality of life to these patients. Thank you very much.
That is a very excellent suggestion, to be honest. And I think it also goes back to what I mentioned, that we are a network of people. So within us, we do have organizations that work in mental health, which we can refer patients to. So referral is a very broad term to mean you are going to look at the patient, you're going to look at their condition, you're going to look at their situation. Sometimes some other patients need to have extra steps for them to be able to have full recovery, and some don't need certain steps. So it's just about us also networking with organizations that can help in such cases as you are describing.
Thank you very much.
Thank you.
Thank you very much. Dr. Bello, have you got a question?
How are you? Good afternoon.
Afternoon, sir.
Yes, I want to thank our presenter sincerely. You have done a very good job. And I also want to thank the organizers. My name is Seydou Bello. I am a maxillofacial surgeon. I'm the president of the Nigerian Noma Society, as well as the vice president of Nigerian Association of Cleft Lip and Palate. And in addition to that, I have also been a partner of SmileTrain for onward of 10 years. So I think by all standards, I'm qualified to be part of this gathering, and I'm highly excited. Excited because
Thank you.
I'm highly excited because I have been on the field, because through my foundation, Cleft and Facial Deformity Foundation, I've been on the field since 2011. And all these cases, they come. I see cleft, I see Noma. Like our presenter rightly described, we have our local ways. I'm commonly based in the north central Nigeria. So let me say northern, closer to the north. And the commonest language is Hausa. So we describe these as Yegegen Lefe. That means a lip that is torn, a disease with a torn lip. So, but when you now say this in a poster or something, what do you expect? Yeah, for cleft, the lip is torn. For Noma, the whole mouth is distorted. So people come for these cases. And of course, this is a question that for years I've been finding it difficult to actually answer. That's why I'm excited when I see that our presenter will be coming from SmileTrain, of which I'm equally part and parcel. Basically, we can never thank SmileTrain enough, because SmileTrain has done so much for Africa and Asia and the whole world, because of their concept of teaching us, developing us, rather than bringing surgeons to our country. So giving us, training us to fish rather than giving us fish. Of course, that has been the big concept all over the years, and it has achieved wonderfully well. Now, before, we did not really have a choice when we had normal cases. But gradually, things are changing gradually. As it is in Nigeria today, we have two centers, two organizations that are equally into the care of Noma. So to a great extent, like she rightly said, that problem is gradually reducing in Nigeria. If your center now, if you have if you come across cleft in maybe any of your probably awareness campaign or something, you come across cleft, you come across a Noma. Now in Nigeria, it's easy to a great extent because we have a Merchants Sans Frontier in Sokoto operating on Noma. We also have Nani establishing a Noma center at Abuja, and this patient could easily be referred. We see how small organizations like my own, we also do repair when we go for outreaches. So that is the situation of things now. Things are getting better. But one thing I still have in mind, probably as Africans, some of us are equally thinking, yes, Smart Train is doing wonderfully well in Cleft. Noma Center and MSF, they are doing wonderfully well in Noma because these are organizations that have defined goals and they are doing well. But I think we are also beginning to think that specialized craniofacial centers should actually be built in Africa. Yes, we could have craniofacial centers. For instance, I pioneer one. We call it Abuja Craniofacial Center for the needy. So something like this, where we can have comprehensive management for all diseases that affect the face. So definitely, as long as the world continues, we could have all probabilities. But this is one area I think maybe partners too that may want to think of facial deformities in general may also be looking into this direction. We need to build craniofacial. We need to build well-equipped craniofacial centers in Africa, such that we can attend to all these cases. Because whether we like it or not, the society is never built equal. The needy will always continue to be, and given the level of poverty and level of low education among our people, we know that we are definitely going to be living with these diseases for many years to come. And as it was said earlier, cleft is congenital. Even cleft is commoner in America than even in the developing world. So cleft will never go away. Agreed. Noma, but you are not to talk of eradication of poverty. So we cannot really say when Noma 2, whether Noma 2 will go in a short while. So to that extent, I want to appreciate Smart Train seriously. I want to appreciate MSF Nani in Nigeria, which is powered by Ilfaxin Noma from Germany. And I want to appreciate our organizers of this program, in which we have opportunity to ventilate and share knowledge. So thank you very much. My regards.
Thank you. Thank you, sir. I know your name. I've just never seen you, so it's nice to meet you.
Thank you, Dr. Bello. Some really interesting thoughts there. I think I agree. That would be very useful. Yona, we have a couple of questions in the chat. A particularly interesting one. Letitha has asked, have you ever had cases of cleft and Noma concurrently, essentially? Are there any cases where you've had both together?
I have seen that only once in 10 years. And this was in Congo back in 2014 or 13, if I remember correctly. It was in Kinshasa. I saw it only once. It was one case. That one, I even my mind cannot forget it. So when I was doing this presentation, I was thinking, oh my God, that child. But they were treated. So we thank God for that. But I have seen it just only once.
Thankfully. Do you know what the outcome was?
The outcome was that they needed multiple surgeries. So this child was about 4 years old, if I remember correctly. They needed multiple surgeries. But by the time I left, I think we could not do a program at that time for some reasons, some instability issues. But as it is, I don't know, because I left Congo about 8 years ago, as it is. But they were treated. I think the follow-up care was the one that I cannot confirm whether they came back or not.
Okay. Thank you very much. Another question from Marta Ribez. Marta would like to know, how often do you encounter Noma survivors in your missions? Is it every mission, or is there a pattern? Are there countries where you tend to see more Noma than others? Do you know this?
Yeah, so when I was talking to Elise, we've heard a lot more about Noma in the western part of Africa, but here in Southern Africa, it's not as prevalent. Like I said, since I started working here in Zimbabwe for Smile Train, I saw it only once, only once. That's the one patient that I also gave as an example. But I've spoken to some of our surgeons, and I've mentioned this also to you guys, that he treats a lot of Noma cases. And like I said, exactly what Doc was just saying now, that Noma and poverty cannot live each other. He was even saying that this year we're likely to see a lot of Noma cases here in Zimbabwe because we had a drought last year. So even the rain this year didn't come on time. So because of that, he's anticipating quite a number of cases. So I will be following up with him, but it would be interesting to see if we see more cases. And I'm also trying to find out, for the sake of this network, from our partners in Madagascar, what the experience there is. And I'll also be coming back to you with that information.
Fantastic. Very interesting. Thank you, Yona. It'd be interesting to see, predictions of increased Noma coming up actually come through, and if there is particular ways we can, counter the impact of that by preparing for it.
Exactly.
Let me just see. Right. I think we have no more questions in the chat. We have no more questions, no more hands up. So, oh, there has just been one more question come in.
Okay.
Sorry. So Matt Fell has just mentioned the observation that cleft is very rarely seen in the lower lip strikes him as important. There's hidden information there about the cause and the embryology of the oropharyngeal clefting. So yeah, quite it's why these observations are so crucially important for the progression of science and behind the disease. So I think that we will end it. We once again like to extend a very big thanks to our presenter, Yona. Oh, Dr. Bala, hello.
Yeah. Thank you very much. My name is Dr. Bala Mujtaba, one of the team members of the International Noma Network and the secretary to Dr. Bello for the Nigerian Noma Society. It's an exciting lecture actually, and when you were presenting and showing some pictures that actually a lot of Noma survivors, especially when they present early, it's difficult if you just from far to differentiate. It's not actually a case of cleft lip. So with this, I'm thinking if the researchers now can explore more. We know that cleft has some genetic influences. If some genetic, researches could be conducted, especially using those genes implicated in cleft as base, that will actually is a good, since we all know that the clear etiopathogenesis of Noma is not yet explored. So the researchers can explore actually into this. Especially me, I have seen cases where cleft also coexist with Noma occurs in patients with cleft. There are some cases, but very few that presented. So I think for researchers, it's just a contribution actually for researchers, they can look into that. They can actually try and use those cleft-associated genes to see if they can find out anything in relation to Noma patients. Thank you.
Thank you.
Yeah.
Thank you, Dr. Bala. Okay, I think we're going to draw to a close there. Once again, very, very huge thanks, Yona. Elise, I don't know if you want to say any words of thanks as well, and maybe give an insight of what our upcoming talks are potentially, Elise.
Oh, yes. Thank you so much. That was a really interesting presentation, and it really reminded me of how I actually got interested in Noma. In the first place is with that difficulty with finding a name. And so at the cleft missions I used to work at, that's where we started seeing the Noma patients, and that's how I got interested in this disease. So that was definitely really, really striking for me. So thank you so much for taking the time. And, I just see so many potential overlaps for how we can work together. So I think it's really exciting. And also us as a network, being more mindful of being involved in the referral networks. So there's definitely a lot of overlap that I can see for sure. So thank you so much for that. And yeah, just in terms of our upcoming webinars, we're going to be having the African Society for Neglected Tropical Diseases doing a presentation about their work and also their funding that's available. So I think that'll be interesting for any of the researchers, the NOMA researchers who are looking for funding for their studies. And then we have a presentation by Dr. Kavanagh from the Ireland Dental Public Health Institute, and they'll be talking about their work on NOMA. And then we have our own Stu Ainsworth also going to be talking on his NOMA micro study, along with Michael. I think they're going to be doing the presentation together. So we're really, really looking forward to that. But if any of you would like to do a presentation, please do get in touch. We would love to have you present at our upcoming webinars. So do get in touch. I'm going to pop my email address in the message box now.
Brilliant. Thanks, Elise. Yeah, so again, thank you everybody for coming today. We're getting really good turnout for all these talks. Really appreciate it. If you could keep pushing them in within your own networks as well. The more people we get talking about NOMA, the more likely are we to make good inroads